So guys, good evening, namaste to all of you. So I welcome you. I welcome you to the class of medicine today, yet with another interesting MCQs. We are going to target about FMG 150 questions, right? But I always say that 150 is not your destiny. Your destiny is to achieve approximately 250 or more than that in FMG examination, right? So first of all, we do have to understand the thing that this quit which is written upon the screen, dreams plus dedication is equal to success. So that was the day when you dreamed to become a doctor, and then for years you showed a dedication, and now you have given a lot of hard work, a lot of struggle you have given, and I hope that all of you have been staying healthy, happy, and you all of you have been staying in high spirits and preparing for your exam appropriately with the full heart, with full dedication. And I wish that all of your dreams may come true. God is with you. Your parents, your best friends, your faculty members, and the team of Unacademy is always there for you, with you. All your mentors are there. So there is nothing that you have to feel, low about you. You just have to be, in that mood that everything is going to be achievable. Whatever you dream about, all you have to remember is that whatever you have dreams, you just have to add on a little bit of more dedication so that the success will become the royal road for you and for your upcoming life, right guys? So as usual, in 8 p.m session we are going to discuss some of the important MCQs, the expected MCQs which can come from medicine. So let's talk about the very first MCQ, and again we will have that 30 seconds of time to solve this question, and then we will discuss about all the options. I repeat, how to approach the MCQ. The first thing we have discussed in the previous sessions, that you have to read the options very carefully, then you have to read the last line what they are asking, and then my dear friend you have to read what's written in the MCQ. Following this pattern, trust me guys, that your subconscious mind will take you towards an appropriate answer and more positive marks will be in your pocket. So here is the, you will have 30 seconds to solve this, and in the chat box I will be looking for your answers. Good evening Shiv, good evening Mr. S, good evening Dr. Kalpana, Akshit, good evening. Good evening Rahul. So good evening Deepak, Shivangi, and many more people. So to all of you, I wish you all the best. So now your 30 seconds has been started. So guys, you have given me the answers already. Now let's discuss what's in the options. In the option we have, the first option is sarcoidosis, then asthma, COPD, right? Then we have pulmonary fibrosis, right? So what they are asking from us, they are asking what is the most likely cause. It's not because, it's cause. So there was I think printing mistake or a spelling mistake, right? So cause. Now let's read the question. A 50-year-old gardener presents to you with progressive shortness of breath. Important line is this, that this patient is having what beta? This patient is having progressive shortness of breath. So try to understand this means progressive shortness of breath. It is not acute. It would have taken quite a long time to develop that kind of breathlessness. His pulmonary function test is suggestive of a decreased FEV1. Very important. What is there? A decreased FEV1 is there, right? A decreased FEV1 there, and a normal transfer factor. What is the most likely cause? So the right answer over here is going to be B, that is asthma. People who were thinking about COPD, guys, we will just discuss now. Now do understand this concept over here. If they ask you FEV1, first of all, do understand this thing. A decreased FEV1 can be seen in obstructive type of lung disease. There can be an obstruction, right? In both the asthma as well as in COPD, you may find a decrease in FEV1. So now this sarcoidosis and pulmonary fibrosis is left because FEV1, there we have to figure about along with FBC, right? And FEV1, we both have to check this thing. Now, my dear friend, low FeV1 give a gas transfer, normal gas transfer, a normal gas transfer factor along with a low FeV1 is basically seen in a acute asthma, where in an acute asthma it can be seen in acute asthma. Right now, this patient is a gardener. Understand this language over here, gardener. So he must be allergic to some of the pollen grains which had led him for this shortness of breath, which have actually reduced his gas transfer over here. Right? Okay, G. Point to be remembered again over here, if they are writing a normal, there it is written a normal gas transfer over here, right? So it is always an acute asthma, whereas in a controlled asthma, you remember we have discussed about the controlled asthma. What you are going to find in a controlled asthma, you can find again a decrease in FeV1 will be decreased. But my dear friend, there can be an increase in transfer factor. Do remember this thing. Increase in transfer factor is mainly seen in an controlled asthma or in a stable asthma. So this was about the first option. Let's go to question number 2. Again, you have 30 seconds. Yeah, Mr. S, I told you that increased gas transfer factor in asthma, but that is seen in a controlled, in a stable asthma. You are right. Mukesh, I really appreciate your knowledge. Time's up, guys. Options are hemochromatosis, Duchenne muscular dystrophy, classical autism, none of the above. Now let's see what they are asking. Which among the following is inherited as autosomal recessive? So you just have to figure out which of the following is autosomal recessive. I think this is a very simple question, right? Now let's read the question. During a routine examination, a patient reports few conditions that he thinks that may have occurred with his family members. Which of the following is inherited autosomal recessive? So among all these guys, answer is going to be the A1, that is hemochromatosis. Now what is this hemochromatosis? So this hemochromatosis, heme का मतलब बेटा क्या है? It is iron, right? So it is a disorder of iron metabolism disorder, right? Which can cause actually iron overload, right? It can cause iron overload, right? And therefore it can complicate or it can lead to things like cardiomyopathy. It can actually lead to a complicated cardiomyopathy. One thing, liver cirrhosis, right? Patient can lead to arthritis also, right? Important point that it's an autosomal recessive. AR means it is an autosomal recessive. Whereas, my dear friend, this Duchenne's muscular dystrophy is a form of muscular dystrophy. It's a form of what, beta? It's a form of muscular dystrophy, right? And this is basically an autosomal dominant, right? Talking about this thing, classical autism. Can you please tell me what is this classical autism? So this classical autism is, it's basically not inherited in Mendelian manner. In a Mendelian manner. Do remember all these guys, these can be one liner or they can be framed about in a story based question or a clinical based question, where you just have to apply your basic knowledge and you just have to remember what are the autosomal dominant, what are autosomal recessive diseases, right? Okay, let's lead to question number next. 30 seconds again. Time's up, guys. We have options COPD, hypokalemia, acute infective diarrhea, and vomiting. Question is, which of the following is the most likely cause? You have examined a patient in emergency department, EBG suggestive of pH 7.2. So pH is already on a lower side. PCO2 is also on a lower side. What is the normal range of pH? Normal range of pH is 7.35 to 7.45. So we know that this is going towards a lower side, right? PCO2 is normal. PCO2 is how much, beta? Is 35 to 45. One thing is very clear. PO2 is also reduced. PO2 is also reduced. Normal range is 85 or more, right? Bicarbonate, what is the normal range, guys? What is the normal range? It is 24 plus minus 2 is the normal range. Now I have given you the values of ABG also, and a picture of ABG is in front of you. Now can you guys please tell me that whether it is a metabolic disorder or metabolic acidotic disorder or alkalosis or respiratory alkalosis or respiratory acidosis? What is all about this question? You just have to think logically, right? So let's understand the concept over here. We know when the pH is going to reduce, along with bicarbonate is also reducing, what is going to happen? It is going towards a metabolic thing. It is going towards a metabolic thing. If, my dear friend, pH is reducing and PCO2 is increasing, what it is going towards? Respiratory. If CO2 is increasing, it is going towards respiratory acidosis. But here bicarbonate is also reducing, so what is going to happen? Acidosis. So right, so one thing is very clear from this picture, that what we have learned, that this patient have landed up into what? In a case of metabolic acidosis. Now first of all, our option number A, COPD, we know it's a case of respiratory acidosis, as we have discussed that CO2 increases over here. But here the CO2 level is reducing. Might the patient has gone into a hyperventilation states, that's why the CO2 level has reduced over here. One thing we have to understand this thing very clearly, right? Now second, my dear friend, pH is reducing, along with the bicarbonate is reduced over here, so it is going towards the metabolic acidosis, right? So we will talk about other two things. Now this vomiting and hypokalemia, this vomiting and hypokalemia causes what? They causes metabolic alkalosis. What they causes, beta? Metabolic alkalosis. Why? Because there is a loss of hydrogen ions and there is a loss of potassium, right? Got my point? So this leads to metabolic alkalosis, hypokalemia and vomiting. Now we know this thing, my dear friend, that what do we know over here? That in the case of acute infective diarrhea, right? In a case of acute infective diarrhea, this patient have landed up over here. So, and this acute infective diarrhea can lead to metabolic acidosis. So the correct answer over here was what, beta? Acute infective diarrhea was the correct answer over here, right? Thank you, doctor. As Dr. Garima, beta, respiratory acidosis, when the CO2 is going to increase, not only then respiratory acidosis is going to occur, right? Okay ji, chaliye, next question. 10 seconds left, guys. Time's up. What are the options? We have Huntington's disease, congenital adrenal hyperplasia, neurofibromatosis type 1, Duchenne muscular dystrophy. And what is the question? Among which of the following is autosomal recessive inheritance? I just told you in the previous questions that remembering about autosomal dominant and recessive disorders is very important. It has never ever happened that in any exam, particularly if I talk about your FMG examination, they love to ask this question. So guys, when you revise, kindly do revise this autosomal recessive and dominant, this thing. So guys, what is the right answer over here? I think this is simple one liner. So congenital adrenal hyperplasia is going to be an autosomal recessive inheritance, whereas this Huntington's disease, neurofibromatosis, and what you call it as this Duchenne muscular Duchenne is what beta? It is basically an X-linked disease, right? This is an X-linked muscular dystrophy, and Huntington's and neurofibromatosis are going to be what? These both are going to be as autosomal dominant. So we are left with an autosomal recessive, that is congenital adrenal hyperplasia, right? Okay. Yeah. Meg, Anshika, Akshit, Garima, everyone claps for you guys, clapping for you guys. You have given me the right answer. Okay, let's lead to question number 5 now. It's a little lengthy question, so here I am giving you 45 seconds to think, right? Okay, time's up, guys. Akshita, Garima, Farheen, Deepak, Anshika, Baljinder, Ankit, Nisi, you all have given me the right answer. Again, once again, I clap for you guys. Right? Okay. So let's read the question. We have short QT interval is commonly seen. It is an autosomal. It is an uncommon cause of sex chromosomal abnormalities. Aortic valve disease is seen in 20 to 30% of the patient. It is not associated with autoimmune disease. And the question is, which of the following is correct regarding this condition? So they are going to talk about this condition, so we can correlate the thing. A 16-year-old girl with short stature, very important history, visits you with primary amenorrhea. Short stature with primary amenorrhea, very important. Short stature, primary amenorrhea. So guys, can you please tell me, where do you find this short stature primary amenorrhea? One thing, while taking history and physical examination, you think of Turner syndrome. Oh, it's written in the question already. It's written in that short stature primary amenorrhea Turner syndrome, right? So you got a clue very well. So guys, let's discuss about the Turner syndrome. First of all, what is this Turner's syndrome? Turner's quick review of the Turner's syndrome. So I am just going to discuss about the important point of the Turner's syndrome. The first very important point, you have to remember that it is the most common sex chromosomal abnormality in females. It's a sex chromosomal abnormality in a female, which is going to affect approximately 1 out of, or let's say, right, 1 out of 2000 live births. So they may ask you this prevalence of live female, particularly beta female births. This thing is very important. They may ask you in this question, right? Another, I have read this also MCQ in your previous question, that this line was there. Is it the most common? Yes, it is the one of the most common sex chromosomal abnormality in females, right? And this condition, it accounts for approximately 15% of all spontaneous abortions. it accounts for approximately 15% of the spontaneous abortions, which with only another prevalence is 1 out of 1,000 embryos they survive. Embryos survive, right? So how many embryos approximately they survive? 1 out of 1,000 embryos survive. Rest, unfortunately, they are under abortion, right? Now, another important point to be remembered over here is this thing that, my dear friend, this happens because of there is a complete, first of all, there is a complete, or you can see there is a partial deletion of X chromosome. X chromosome, right? Most common clinical features. Most common clinical features. Hanji, what are the most common clinical features? Can you please write me in the chat box, guys? Yes, the most common clinical features are. Hanji, I'm waiting for your replies, guys. Can you please write me in the chat box? What are the most common clinical features? Yes, my dear friend, the most common clinical feature is short stature. Deepak, very good. Short stature, primary amenorrhea, right? Now, another clinical features, other clinical associated clinical features, that this patient can have a broad chest. Patient can have a broad chest, widely spaced nipples, widely spaced nipples, right? Patient can have a vivid neck, and a low hairline. Low hairline is there, right? Complications, this patient can also develop some complications, guys. They may ask you this question, that what are the complications. This patient can land up into pyelonephritis, right? And sometimes they also land up into hydronephrosis, right? They have some complications like coarctation of aorta, approximately in 3 to 10% of the people, right? Patient have aortic valve disease for approximately 20 to 30% of the cases. Patient develop hypertension also. They can have a prolonged QT interval. Prolonged QT interval, right? So this was all about the Turner's syndrome. So what is the right answer over here? We have discussed about this aortic valve disease, that aortic valve disease accounts for approximately 20 to 30% of the people. So yes, my dear friend, option number C was the right answer over here, right? So people, you have given me a very appropriate answer. I really appreciate your knowledge, and I'm pretty sure you have been revising and you have been preparing for your exam wonderfully. So let's proceed further, beta. A very simple one-liner MCQ. Very simple. I think I need not to give you even 30 seconds. So Klebsiella pneumoniae, Staph aureus, Streptococcus pneumoniae, Clostridium perfringens. Which of the following microorganism is not a gram positive? So let's quickly revise about some gram negative routes and gram positive routes. So let's make a table quickly, and then you will give me the answer. So here we are going to discuss about, first of all, gram negative nodes. and here we will discuss about the gram positive. So guys, you have to tell me in the chat box and I will write down. Can you please tell me some of the examples of gram negative roads? Yes guys, I am waiting for your replies. I am waiting guys. Yes, Dr. Nishi, it is going to be yes. I really like your answer, that is Klebsiella. Klebsiella pneumoniae. One is Klebsiella pneumoniae, very good. E. coli, okay. Then Pseudomonas aeruginosa, Haemophilus influenzae, right? Legionella pneumophiliae, Legionella pneumophiliae, right? These are some of the examples of the gram negative rods. Can you please be kind to tell me about the gram positive rods? Hanji guys, can you please tell me about the three important things most commonly asked? Gram positive. So gram positive includes, one is Listeria monocytogenes. Listeria monocytogenes, right? What else guys? Beta, I am asking roads, not cocci, right? Then Clostridium, and the third one is Bacillus, right? So guys, do remember this thing. When they ask about this thing, they are particularly mentioning this thing, right? Now you are giving me answer as Staph aureus. So guys, let me also discuss about one important thing over here. Let's make a table and quickly revise this thing. So to grab some more points, you have to be very smart enough to read what they are asking. If they are asking gram positive cocci or gram negative cocci, gram positive cocci, and we have gram negative cocci. In gram negative, do remember one important this one, that Neisseria, meningitis, and gonorrhea are going to be the gram negative cocci. If they ask you about the gram positive thing, then my dear friend, what you are going to answer is, first of all, Staphylococcus. What you are going to answer is Staphylococcus aureus, right? Then Streptococcus, species like Pyogenes, Viridians, right? Pneumoniae, right? These all are going to be the gram positive cocci. I hope we have quickly revised this. And now can you please tell me guys, what was the right answer over here? The right answer was Klebsiella over here. So let's proceed to the next question. Just a second. Guys, this is question number 7. Not 8, just a printing mistake. Guys, they are asking left. Read the question carefully. Read the question carefully, guys. So increase in 2,3 DPG concentration, increase in pH, increase in CO, right? Increase in hydrogen ion concentration. What do you think? Which of the following condition hemoglobin dissociation curve shifts to left? So guys, quickly answer me. An increase in 2,3 DPG, right? Then my dear friend, hydrogen ions and increase in carbon dioxide, right? They are going to cause a hemoglobin dissociation curve to shift towards the right. First of all, so we are left with only one option. That is what beta? Increase in pH is going to make the dissociation curve to shift towards the left, right? So Akshit, Madi, I welcome your answer. Yes, Dr. Kalpana, very well said. Right, okay. So this was a simple one-liner question. Let's proceed to the next question. Thirty seconds again, guys. Yeah, Mehdi, this was a previous year question also. So in this question number 9, I would like to ask you what this patient is dealing with. 47XXY. What is it, guys? What is it? Yeah, Baljintar, it is going to be a Klinefelter syndrome. So first of all, you just have to recall about Klinefelter syndrome. Now, guys, you can answer me appropriately or you can answer me the right option which you want to choose. Klinefelter. Guys, you are saying me option number C. I don't agree with your point. I don't agree with your point. I will discuss why. Now, I will let's just discuss. They are asking about the Klinefelter syndrome. Now, do remember this thing. If you have read about the prevalence, this is very important, guys. Now, prevalence of gynecomastia in a case of Klinefelter syndrome is only seen in 40% of the patient. Is only seen in 40% of the patient. Whereas in this question, it is clearly written almost. Word they are using, what better? They are using the word almost, means they are saying approximately 80, 90 or maybe 100% of the patient, where the prevalence of gynecomastia in the Klinefelter is only seen in 40% of the patient. So option C is depleted. Now it's not the right answer. Rest of the three options you have to choose. Now choose, guys. Mukesh, Akshit, art time, absolutely right, guys. So it results in a mean adult height close to 75 centile, right? Now let's talk a little bit about the Klinefelter syndrome. What patient can have scanty hairs? Characteristic: scanty hair, right? Patient can have a little facial growth, facial hair little, whereas here it is written excess, right? Do remember this thing, my dear friend. It does not cause moderate or severe mental retardation. No, it is not associated with mental retardation. Only maybe because of some other associated illness or maybe due to some other disease, mental retardation is there, but there is no significant mental retardation if it is a pure case of Klinefelter syndrome, or you can call if there is a complete 47XXY, guys. And do remember, I have purposefully made this point over here. I have purposefully made this almost. Do read this carefully and do revise Klinefelter, and you will find, guys, that approximately the prevalence of gynecomastia is only seen in how many patients? Approximately 40% of the patient. So don't be in a hurry to answer and quickly you look at gynecomastia and you think that yes, gynecomastia is the feature. So these are the silly mistakes. which we are going to do in the exam. So kindly avoid these silly mistakes. Let's lead to the question number next. आई एम गिविंग यू 40 seconds. जस्ट भाईबंदी में मैं 10 सेकंड और दे रहा हूँ आपको टू थिंक, बिकॉज आई थिंक यू नीड टू रियली थिंक व्हाट दिस पेशेंट इज डीलिंग विद. Ten seconds left, guys. Guys, if you have read about this, options and try to correlate the options with the history, trust me, guys, you are going to find a right answer over here. So you are giving me Baljinder D, Deepak B, Deepak Kumar Singh C. C is psychogenic polydipsia. D is all. Okay, let me read this. On dual treatment with loop and potassium sparing diuretics, syndrome of inappropriate antidiuretic hormone, psychogenic polydipsia, all. Okay. Akshat and Pooja, why do you think it is option A? Why do you think? Is it just a fluke, or you are going to give me a right answer, right explanation also? Actually, the answer is A over here. I do agree with your point. Now, let me explain this. Which of the following is likely to be associated? So, let's correlate this. On dual treatment with loop and potassium sparing diuretic, SIAD, psychogenic polydipsia. A 58-year-old man presents to your OPD with complaints of long history of dyspnea. Very important, guys. Long history of dyspnea. Long history of dyspnea. Right? Now, guys, dyspnea, just put your pens down and understand what are the causes of dyspnea. So, causes of dyspnea can be cardiac causes, causes of dyspnea can be pulmonary causes, or it can be a hematological. Likely that patient, if anemia, they can also have dyspnea. Right? Now, how you have to, differentiate between the cause, whether it is respiratory, whether it is going to be a cardiac cause, or whether it is going to be dyspnea because of anemia. Very simple. You just have to look at the lab reports. Anemia means HB is going to be on a lower side, right? If dyspnea of respiratory system, then my dear friend, either in the exam they will be mentioning you some other history of allergy, like say the patient is having asthma or atopy, or some history should be there. COPD should be there, or maybe patient is having some kind of ILD or some pneumonia or something like this thing. But in infective diseases like pneumonia, there is no long history of, there is an acute history, short history of dyspnea. We are very clear about this thing. They must be mentioning about some lab investigations, ABGs, or maybe some pulmonary function test, right? Now, if we read this question carefully, there is saying that this patient is having a long history of dyspnea and his lab reports are suggestive of this. What is this? Hyponatremia. One thing is hyponatremia. Serum sodium is on a lower side. What is the normal value of serum sodium? Normal value is 135 to 145 millimoles per liter, right? Then potassium is on a higher side. Potassium is on a higher side. What is the normal value? Potassium ranges between 3.5 to 4.5. Got my point? So potassium is on an increased side. Bicarbonate is also increased on a higher side. Urea little increased over higher side. So why this urea is increasing and sodium is getting retained over here? Do think and do correlate with the options over here. Now, first of all, my dear friend, means I have discussed about the causes of shortness of breath or dyspnea. So first of all, managing with this kind of sodium, what I think is this, that this patient had landed into a cardiac failure, right? This patient must have a history of cardiac failure, and we know this thing, that the cardiac failure most common presentation is shortness of breath. Might be this patient has went into a fluid overload where the doctor has given him some diuretic to decongest that patient. Now we know that forced diuresis will lead to a low sodium level and a high potassium levels. Got my point? Because this patient is landing up into dehydration, most of the fluid is getting lost because of the diuretic use. That's why the urea is also increased and the bicarbonate has also increased. So do remember this thing: hyponatremia, low sodium, and hyperkalemia. And hyperkalemia, one thing, it's a common finding of patients who are on loop and potassium sparing diuretics, who are commonly using this loop and potassium sparing diuretics. Now, let me also discuss one another important cause where you can also find this thing: hyponatremia and hyperkalemia, my dear friend. What is that? That is called as Addison's disease. That is also seen in Addison's disease. It may also produce this hyponatremia and hyperkalemia. But since this was not in an option, just a quick review of this, so that you can also, if in the option you can come, you do remember this thing, that in Addison's you may also find this same lab investigation or biochemical abnormality of hyponatremia and hyperkalemia. Right? Okay, Ji. Can we move to the next question? Again, a very simple question, I think. Yeah, it's very simple. Staph aureus, H. influenza, Listeria, Pseudomonas aeruginosa. You take a blood sample from a febrile patient. On blood cultures, it's suggestive of gram-positive cocci. We just discussed gram-positive cocci. Which of the following is the likely organism? So answer is going to be yes. It is going to be the Staph aureus. Right. Now, guys, do remember this thing. This Staph aureus is going to be, an important cause of bacteremia, right? So it is always important to differentiate between the methicillin sensitive or methicillin resistant Staph aureus. So if you are able to segregate this thing, it is always beneficial to start the effective therapy or effective treatment depending upon whether this Staph aureus is methicillin sensitive or methicillin resistance, right? So if they are asking you about MRSA, methicillin resistant Staph aureus, what is the drug? Hanji guys, what is the drug? I'm just asking a drug for MRSA. Another question. Drug for MRSA. Please write me, do write me in the chat box. Yeah, drug for MRSA is vancomycin. Yeah, I do agree with your point, but if I write VRSA, what is the drug for VRSA? For vancomycin resistant Staph aureus. Guys, what is the drug for VRSA? Yes, Paras Patel, I really appreciate your answer. It is going to be linezolid. Absolutely right, guys. Absolutely right, guys. Okay, so let's proceed to the next question now. Five seconds left, guys. I really enjoying having a discussion with you because approximately all of you are giving me a right answer over here. So let's read the options: frontal lobe, occipital lobe, temporal lobe, dominant, parietal lobes. So based upon this, one thing is very clear, that this question is going to talk about some functions or some abnormalities of specific areas. So what you have to recall quickly, you just have to recall what are the functions, or what if there is any abnormality in this particular region of the brain. Let's read the question. 75-year-old female was brought to your clinic because of preservation, important one, inability to spell word backwards, or to interpret proverbs. For this deficit, which region of the brain is likely responsible? Yes, my dear friend Mehak, Art Time, Baljinder, Dipanjali, Mukesh, absolutely right. Yeah, interpret means or interpretation, guys. One of the same thing, Dipanjali. Right. So the answer is going to be the frontal lobe over here. So this answer is going to be the frontal lobe. See, these are the what you call it as neuropsychological deficits, which are basically, associated with a lesion in the frontal lobe, right? Which are associated with a lesion in the frontal lobe. Now, this frontal lobe is basically responsible for attentional process, which is required for a lot of cognitive functions over here, right? So if they are saying that there is a problem in the preservation and the patient is not able to spell some of the words, then do remember the functions of the frontal lobe. So this frontal lobe is going to be the answer over here. So there must be have some lesion or some abnormality in the frontal lobe. That's why this patient was not able to spell a word. So I really appreciate your answer, Deepak, and everyone who has given that answer A. Hanji guys, 5 seconds left. Okay, I am giving you another 10 seconds to think, guys. Think now. Time starts now. Another 10 seconds. Okay, you people are giving me A. A is not the answer. A is not the answer. Now we are left with hypothyroidism, adrenal insufficiencies, and sample hemolysis. Think, guys. 50-50 I am giving you the. C is also not the option. Now you have to choose hypothyroidism and sample hemolysis. Let's play KBC. Now you are giving me B and D as the answer. I really enjoy your, this smartness. Some of you are thinking B is going to be the answer, but I am not receiving the perfect answer over here, guys. Look, renal tubular acidosis, hypothyroidism, adrenal insufficiency, sample hemolysis. It's a very simple question, my dear friend. That a 50-year patient is seen by you because of persistent tiredness, right? Persistent tiredness. You do an investigation. All other lab reports are normal. क्या है बेटा यहाँ पे? All other lab reports are normal. क्या है? All other lab reports are normal, right? Normal. Apart from potassium, 6.5 millimole, right? Now you are giving me hypothyroidism as an answer, whereas if it had been an hypothyroidism, then patient would have some lab reports in the MCQ. First of all, this thing. Tiredness is just not going to be because of hypothyroidism. There are many other causes of tiredness, right? Now, guys, do understand this is basically an isolated hyperkalemia. First of all, isolated hyperkalemia. And this isolated hyperkalemia is basically most commonly seen where there is a delay of, examining or examining the blood for the potassium level. So what happens if there is a delay of the sample to reach to its machine where you examine that potassium, the value of the potassium. So in that meantime, if there is a significant delay, there are chances that this blood will get hemolysis and will give you a factitious report, right? So they can give you a factitious report. So do remember, in presence of any other significant clinical feature, if they are giving you only value of potassium, it could be a hyperkalemia, and this hyperkalemia is generally seen in those conditions where you have a delay in examination of the blood for the serum electrolyte, because my dear friend, this blood, it gets hemolysis very quickly and it may give you a factitious report. So it is always advisable to recheck or re-examine or take the blood samples of the patient and do an re-examination of that blood sample. Got my point? Okay. Because in this question, apart from tiriness, there is no other clinical history. So I'm not taking any other option. So we are left only with this one option, that is sample hemolysis. So yes, Paras, this is quite a tricky question, right? Yeah, because now only a few days, or let's say countable time is left. So you should have that smartness to pick out all these questions. Again, 30 seconds. Guys, let me put this as factor 8. So this is factor 8. Guys, please read the option as factor 8. 8 I am writing over here. Because we have this factor 7 over here. So I've just made a printing mistake over here. So do correct this thing. This is A is factor 8, or you can, yes, I will stick with this factor 8. Now read the options carefully and answer me. Deepak, Mukesh, Dr. Nancy. Okay, art time. Okay, so we have options: factor 8 deficiency, lupus anticoagulant, factor 7 defect, or deficiency. You can think decrease factor 11. So, guys, 45-year-old female was referred to you with prolonged PTINR and a normal what? And a normal PTT and a normal PTT. Which among the following abnormality you suspect the most? So let's discuss about the thing. Anyhow, the answer is going to be the factor 7 defect. The answer, people who have given me that answer, Deepak, Mukesh, Nancy, Art Time, Baljinder, I really appreciate your answer, and other people who have also given me as the answer C. So let's discuss beta what happens. Let me have a quick review of this, coagulation factors. First of all, do remember this thing, that the PT or the PTT, it basically evaluates the coagulation factor कौन से factors evaluate करता है बेटा? Can you please tell me? PTT evaluates which coagulation factors? Quickly, can you please tell me? So it evaluates factor 2, which is also called as prothrombin, right? Then 5, 10, It evaluates 8, 9, 11, and 12. So it's going to evaluate this thing, right? Second thing, you have to always keep it in mind that a PT test with INR, it evaluates coagulation factors, which evaluates factors like 7, 10, 5, 2, and 1, that is fibrinogen. Right. Quickly, I'm just telling you that if there is isolated factor 7 deficiency, if there is isolated factor 7 deficiency, it would result in a prolonged PT INR with a normal PTT. Right? So do remember this thing, guys. This is important feature. So what do we have? There is a prolonged PT and a normal PTT. So we have discussed. Do kindly revise this thing and be very smart, or be very quick to read this question carefully and among the options. So again, this was a tricky question. So you just have to revise which intrinsic and extrinsic factor is what you call it as evaluated with which coagulation factor. Okay. You have 30 seconds, guys. Quickly go through this. Okay, time's up, guys. We have options: acute tubular necrosis, acute glomerulonephritis, interstitial nephritis, and myeloma. So I have received one right answer from Biljinder. Okay, which of the following is the most likely cause of a renal failure? A 60-year-old female presents with constipation. Very important: constipation, thirst, backache. So you just have to correlate where you can find this and why you find this constipation, thirst, and backache. She is not on any medication. We know that some of the medication, they can lead to thirst or constipation, right? Lab reports, very important, right? Now HV9 means this patient is anemic. TSH, urea is increased over here, serum creatinine is also increased over here. Potassium is going to be we can call it as slightly increased over here. So ultrasound abdomen is normal. Which of the following is the most likely cause of a renal failure? Now, why there is renal failure? Do understand, urea is increasing, creatinine is increasing over here. So guys, can you please rethink what is the option over here? Guys, see, I'm just going to take these things: constipation, thirst, backache, right? First of all, do remember this thing, that why this patient is having all this constipation, thirst, backache, right? So basically what is happening, there can be a hypercalcemia. Now this hypercalcemia can be because of this hypercalcemia is associated with, first of all, let me tell you the right answer, it is the myeloma. Now, what happens in a case of myeloma, that these patients, they basically land up into thirst, or sometimes they can have a abdominal pain. Now, why this thirst and abdominal pain occurs? Because, my dear friend, first of all, these patients are very prone to develop some peptic ulcerations, right? They are developed to prone to develop renal stones and pancreatitis, which can lead to, abdominal pain or thirst or constipation, right? Now, this hypercalcemia can basically lead to a backache. First of all, do remember this thing, right? Hypercalcemia is basically a complication in multiple in myeloma, right? Right. Second, my dear friend, because this patient is thirst or patient is dehydrated over here, because of why the patient has dehydrated over here, because you see over here the patient is having an increase in urea and creatinine. So, and why they have increased? Because there can be a renal failure which is secondary to what you call it as tubular dysfunction, right? Now, tiriness is there. Why tiriness is there? Tidiness. Okay. This patient also go for tidiness. This patient is also have tidiness because anemia is there. 9.5 gram is the um, uh, hemoglobin over here. So these patient can also present to you with this tidiness over here. Again, constipation I am telling you because of hypercalcemia, right, and dehydration as the urea has increased. So we are only left with one option, that is myeloma is going to be the right answer over here. In myeloma, hypercalcemia is a complication over here, and because of this hypercalcemia, constipation is there, right? There can be secondary tubular dysfunctions which can lead to a renal failure also. So this was the myeloma, which was the answer. Okay, next question, please. Time's up, guys. Options are lifelong, 1 year, 6 months, 3 months. And the question is, for warfarin therapy, what is the most appropriate duration? A 30-year-old female presents with right DVT, which she develops after a prolonged flight. So one thing is very clear. Do remember this thing. DVT can causes of DVT can be a prolonged immobilization, right? They ask a question just out of this question. I'm just going to just tell you about 2 3 things about DVT. They ask you 2 3 questions. What is the most common preventable cause of death in hospitalized patient? This is a previous year question. So it is DVT, right? Preventable cause of death. Why? Because you can prevent this DVT by putting some pneumatic stockings, or you giving anticoagulant to that patient, or mobilizing the patients in the bed, or you can take out, if the patient is not that sick, you can also take the patient out of the bed. Just by mobilizing, you can prevent the DVT. Anyhow, coming back, she was previously taking oral contraceptive pills. So OCPs, we know they can cause hypercoagulability, and hypercoagulability can also lead to DVT. But now she has stopped and is taking other measurements for contraceptions. Very good. She is found to be heterozygous for factor 5 mutation. This is very important. Heterozygous for factor 5 mutation. For warfarin therapy, what is the most appropriate duration? Hanji guys. So you have given me answer as how many people have given me answer? Baljinder, Hirishi, Paras, Art Time, Nayan, Art Time. Deepak, yeah. Kalpan, and many more have given me answer as appropriate answer is this one, 6 months. Now do understand the 6 months is going to be the right answer over here. Do remember guys, people who think that 3 months is going to be the answer. Let me take one by one. Mukesh, like you are thinking, right? 3 to 6 months you are saying. So if there is no precipitating factor, 3 months, if there is no precipitating factor, no, if there is no precipitating factor beta, only then you are going to give warfarin for 3 months. For how many months? For 3 months. But read the question carefully over here. There is this patient is already heterozygous for a factor 5 laden mutation. Do remember this thing. So 3 months therapy is only recommended if there is no precipitating factor. So this option is out over here. But now, if you have read this question, this patient is heterozygous for factor 5 laden mutation, where you need to give at least a minimum of 6 months of warfarinization to this patient. How many months? 6 months of warfarinization is required with this patient, right? Earlier it was thought that a lifelong warfarinization is required, but my dear friend, for that, two or more than two, how many? Two or more than two thrombotic events was mandatory over here. Kya hai? I repeat, if there had been any heterozygous or any problem in the previous, along with two or more than two thrombotic events, have been witnessed, only then we are going to give it for a lifelong. If not, then obviously 6 months is okay with this patients, right? So guys, do remember this thing, 6 months of warfarinization therapy is required if there is some precipitating factor. If not, then my dear friend, then 3 months. If two or more than two events, then a lifelong warfarinization is required. So guys, I hope you have enjoyed this session and you have grabbed a lot of knowledge, and I am pretty sure that you have quickly revised the important touch points of the medicine, right? So I will meet you in the next class. Till then, take care, keep on revising the things, keep on revising the important tables of Harrison. That's what you can do as of now, and trust me guys, you are going to rock the show. Have faith in yourself. All the positive powers, all the positive prayers, best wishes of your family members, your friends, your teachers, and your mentors are always with you. Do remember one thing, that dreams plus hard work and dedication leads to success. So thank you very much guys. Take care. Good night.